might have a couple
Sure.
more people trail in as the time goes on. But hi, everyone. Thanks for coming today. This is our second talk on PM&R. Today we have Dr. Wu, who is going to talk about the conservative management of cervical spine disorders. And just a bit about Dr. Wu, he cares for patients with chronic back, neck, and other kinds of musculoskeletal pain. He uses ultrasound and X-ray technologies to perform image-guided injections to alleviate pain. And he also uses regenerative therapies like platelet-rich plasma. So a lot of exciting stuff, and we're excited to hear from him today. So thank you for being here, and thank you for presenting, Dr. Wu.
Sure. You're very welcome. Thank you for having me. I'm happy to present today's talk on the way physical medicine and rehab manages cervical spine disorders in a conservative way. So go ahead and start and introduce my service, which is, we're part of the UCSF Non-Operative Spine Service, which is within the section of PM&R and falls into the Department of Orthopedic Surgery. And these are our providers. Currently, there's 4 of us. We're expanding to a 5th provider pretty shortly. And I think you'll be hearing from these folks in this talk series coming up later in February or March. So we practice at different locations around the UCSF campus. Also satellite clinics in the East Bay and North Bay. I understand, so you guys had a presentation by Dr. Del Rosario for the first talk in this series, and I hope she laid out sort of the lay of the land for PM&R, but I created this slide hopefully to help folks locate where my service, at least, fits within the broader PM&R scheme and framework. So hopefully she presented multiple subspecialties of PM&R, and then you'll hear from different providers on those. The way I can sort of conceptualize PM&R subspecialties, if you look at just the main table, there's an outpatient setting and an inpatient setting where folks practice. And so if you guys are considering a career in PM&R, this could be one type of breakdown in terms of if you prefer an inpatient type of practice or outpatient. Those practices that span both kind of have practices within both settings. Sometimes it's related to surgical needs that the patients are inpatient. Sometimes it's more of a consultative role on the inpatient service for example, those ones that span the midline, pediatric rehab, amputee care, medical rehab, which includes cardiovascular, respiratory, cancer rehab, which are all emerging fields of rehab. Musculoskeletal, it can span post-surgical, especially joint replacements that relate to the orthopedics area. Those on the left half, which is outpatient, fall within the neuromuscular area where they do EMG studies, sports medicine, treating athletes. And then spine and pain is somewhat of an overlap area where we're all outpatient for the most part, and we see patients with acute or chronic but non-emergency or non-surgical types of issues. On the inpatient side, you'll hear about brain injury, stroke, and spinal cord. The other way to think about it on the left hand of this slide is that a lot of rehab, and the goal of rehab is to restore function, works on a spectrum of dealing with central dysfunction. So if you imagine central, the highest being the brain, where people have brain injury or stroke, all the way towards the bottom, which is peripheral dysfunction, which is orthopedic or limb or periphery. So I laid out these subspecialties along the spectrum, going from central to peripheral. The right half of the slide demonstrates just the overlap because PM&R is so broad in terms of the different departments, the different areas, the focus of training that you might emphasize if you subspecialize in one of these areas. That, for central dysfunction, you work in neurology, pain with anesthesiology, the medical aspects with either family medicine, primary care, internal medicine, and then typically what we find on the West Coast is PM&R being aligned with orthopedics. These are also departments where you might end up receiving fellowship training for these areas to subspecialize in. So for example, my training was in pain, and then the fellowship program was sponsored by the anesthesiology department. So that's the majority of cases for pain. So I'd like to just start and go through this talk. Won't spend too much time on each particular slide, but probably use this case to go through how we manage.
Wow, this is really good. Then
Okay, so the case this exemplifies the complexity of a particular neck disorder patient. He has neck and shoulder pain and arm numbness. He's 55, has a history of hypermobility, a remote history of a ski accident injuring his neck, but resolved, and presents after he had a motor vehicle accident in which he was a motorcycle rider that got hit by a truck, presented to me about 6 months afterwards with injuries, multiple injuries to the spine, but were all managed without surgical intervention, brain bleed from that injury, and then some PTSD from that trauma, and complains about neck, shoulder pain, dysesthesias of the upper extremities, and a presentation of itchiness along the outer aspects and tops of his forearms. So that's fairly common. Here's a catalog of his injuries from that motor vehicle accident. So multiple areas of the vertebral bodies as well as thoracic vertebral bodies. Nothing was really displaced, luckily. And then some of the vertebral fractures in the neck did affect the foramen where the spinal nerves exit, but didn't really impinge or anything like that. So he was fairly lucky. He did have to undergo a lot of recovery to allow for these bones to heal and then the pain to subside. His description of the pain was 4 to 8 out of 10, achy, stabby, burning, flame-like pain in the neck, thoracic spine. So that spans a spectrum of what we think about inflammatory and nerve types of pain based on this description. That was associated with numbness, tingling, dorsal forearms, entire hands and all fingers. Couldn't really achieve full strength in the third digit, both hands, some discoordination, some weakness, also some visual disturbances and kind of walking imbalance. Everything was worse with lying on his back, but better with lying on his sides. So in terms of seeing this type of patient, we'll go through a little bit of background as to epidemiology of neck pain. So age-related degenerative changes are almost universal. They may begin as early as the first decade of life. Population studies have shown that about 80 to 90% of folks have disc degeneration on MRI by age of 50 years. Clinical features of this type of degeneration called spondylosis are more common in men than women, with peak incidence in the 40s to 60s. At any point, and this was a CDC survey in 2009, neck pain can affect 15% of the population with that incidence every 3 months. There's a prevalence annually of 37% and a lifetime prevalence up to almost 50%. And neck pain results in increased healthcare costs, expenditure, missed days from work, reduced productivity, rising insurance costs, amounting to billions of dollars of healthcare expenditure. Virtually all patients have some degree of degeneration with age, including disc degeneration, foraminal narrowing, bone spurring, facet arthritis, which are the joints in the spine. Why some patients have symptoms and others don't is unclear. It could be related to anatomical configurations or genetics, especially if they have a narrow spinal canal where the spinal cord travels. And then a lot of it relates to contributions from lifestyle risk factors for developing symptoms. So including poor sleep, stress, smoking, overall poor health, being sedentary, having history of neck pain in the past will have increase or associate with increased risk of having neck pain in the future, just as it is with low back pain. History of trauma and repetitive work injuries. So we kind of see a mixture of how neck pain presents, and it's a mix of both nerve-related and generally sort of local tissue pain-related pain. 50% or over 50% of folks will have some mixture of nerve involvement in their pain, and then less than 50% will have strictly just local pain, inflammation, not nerve-related. Typically, nerve-related pain is for the most part radicular, which is spinal nerve root issues, and that contributes to the overall pain. It's related to degeneration, and possibly underlying that is disc herniation. With nerve involvement, nerve-related pain, it's greater likelihood of having chronic pain and psychosocial involvement and functional impairment. And briefly for these slides, I'll just go through the highlight points. So if patients present with acute pain, we typically expect acute pain, whether it's sort of a lifting injury or sleeping on the wrong side of the bed, something where they tweak their neck while at the computer. Typically it resolves over a couple of months. About 50% continue to have low-grade symptoms, recurrences and flares, and beyond a year. And so these are similar risk factors for transitioning from acute to chronic pain. When it involves spinal nerve roots, there's a worse prognosis than if it was strictly just neck pain, like a muscle knot or something in your shoulders. They typically will improve. So 50% disc herniations decrease after 6 months, and 75% decrease even further when it's further out in like 2 years or so. So most of the cervical radicular pain will improve by 6 months, and we educate our patients that it may take anywhere from 6 months to 2 to 3 years for them to actually feel better or for their actual issue to subside. Recurrences will occur, but for the most part, a great majority of patients will feel better years on out. Stenosis, which is more of a degenerative process in the central canal, you'll hear is not necessarily the same process, and it is sort of a progressive thing. And when that does progress, it sort of narrows down on the central aspect where the spinal cord travels, and that typically is what we call like a myelitis or a myelopathy. And that can lead to upper motor neuron signs. It suggests something central is happening rather than just the nerve roots. Leading causes in the young patients are trauma, and older patients, it's degeneration. So it's highly variable. It's not always the same natural history, expected natural history from a disc herniation. You might have, periods of relapse, then recurrence and progression over years. And typically that is, down that road is an indication for surgery at some point. We look for key points in our history taking to figure out what the source of pain is. So we ask about the history. Trauma is especially important and particularly relevant for this case, versus like degeneration. We ask for past medical history that might associate with increased risks for neck issues and nerve issues. Some of it might be congenital, some of it might be incurred. So if they have repetitive work injury, they'll have probably some impingement and then prior surgery. So we look especially for neck surgeries, prior shoulder surgeries. And shoulder surgeries, if their shoulder pain, can confound the picture a little bit. We try to split up the differential diagnoses into whether it's really nerve related or really just inflammatory or nociceptive. So we kind of listen to the descriptors of pain, whether it's nerve related is burning, electric shooting, and nociceptive, which is more like the achy, deep, throbby. But there's always overlap. And so some nerve related compression might initially present acutely as central pain where the disc hurts. And then as that disc essentially bulges out later on, they may start feeling the nerve pain that might run down their arm. Some arthritic pains will just feel like stiffness in their neck. Beyond that, we try to isolate if, after we kind of think about if it's nerve or axial, where that pain is coming from. If it's axial, think about something that's in the center of the spine. So disc or facet joints or muscles that sit along either side of the spine. Some of it can actually just be muscular pain, and that's reactive to something that happened to the disc or something deeper. And so that can accompany a possible disc herniation as well, and may contribute to over 50% of the actual symptoms. And then we think about if it's more than axial and it actually goes down the arm, whether it's actually radicular, which is what we call radiating pain down the arm, or referred pain, which is where you have pain that just kind of feels like it's felt somewhere different than where the actual source is. We try to match dermatomes to the nerve roots to determine which nerve root might be involved, but oftentimes it's not a one-to-one correlation. There's always a possibility that there's overlap in different nerve roots causing the same type of symptom. Then we try to determine even more whether there's exacerbating postures or activities. Things like coughing and sneezing can aggravate discogenic pain that might secondarily affect nerve root pain. And then we ask, in addition to that, some alleviating factors. We factor in whether or not there's a likelihood of increased progression to chronic pain if they have mood disorders, like this patient has PTSD, sleep disorders, which this patient also has. He has obstructive sleep apnea. So anytime disruption to mood and pain occur, it can actually amplify patient's pain. We look for ruling out associated factors or alternate diagnoses that say it's non-spinal. So CRPS, which is a neurogenic or neuropathic type of condition, can often cause arm pain in a nerve type of presentation, but it's not actually related to the neck. There are strict criteria to rule these things out, for example, for CRPS. We try to rule out red flags or identify red flags and surgical indications. So especially if they have motor weakness, some discoordination that can't be explained, sensory loss, so we test out the light touch sensation, upper motor neuron signs, constitutional symptoms that might suggest maybe an oncologic process. And we try to identify whether or not there are underlying past medical conditions that their symptoms can be attributed to beyond the spine. So for example, rheumatoid arthritis is associated or predisposes to the risk of subluxation of the upper vertebral bodies in the spine, as this arrow points out on a sagittal view of an MRI. We can see that there's the atlas is displaced forward, and I'm pointing out here that it's actually displaced so that it's pinching the spinal cord. And so we kind of watch out for those predisposing past medical issues. And specifically for central stenosis, we try to expand our thinking to the possibility of myelopathy, which is going to present in not just upper extremity symptoms, but also might lead to lower extremity symptoms because it's impinging on the spinal cord, which carries all the nerves that goes down to the sacrum. It could be weakness in the legs, discoordination, and balance problems, and not just neck pain. So we always have to keep that watchful monitoring for these other types of symptoms. Beyond that, we look for a history of medication use to help us guide our current management plan. Interventions tried, rehab tried, alternative therapies tried. So going back to our case, this patient had already presented 6 months after his accident, having tried a nerve pain medication, Cymbalta, muscle relaxant, methylcarbamol, anti-inflammatories, Tylenol, opioids, which are for breakthrough pain. He's explored cannabinoids, topical approaches as well. we kind of look for limitations in the options that we have available. So he's tried nerve pain medications that have resulted in intolerable side effects. So we don't really try to repeat those in the future. We try to look for alternative options in the same class or same type of medications to help better manage his pain. Unfortunately, he has reflux and he couldn't really tolerate the anti-inflammatory class. So that was kind of a restriction for our choices. He's also tried multiple rehab measures, including physical therapy, which is always what we try to incorporate as part of our care. He's tried modalities so going down the list, he's tried sort of mechanical therapies of inversion, mind-body exercises like yoga, Pilates, Feldenkrais, passive modalities where he has chiropractic manipulations and massage, modalities like ice, heat, and therapeutic ultrasound, which is another way to introduce heat but deeper into the soft tissue, and then complementary therapies like acupuncture, and then cognitive behavioral therapies like meditation. So once hearing the patient's history, we started thinking about what it could be, what are likely pain generators. And so breaking it down to the way we collected our history, we think about what's axial pain. So axial pain can be discogenic. Associated symptoms with disc-related pain are headaches. It can refer to the shoulder. Doesn't really travel that far down the arm, so it's not radicular. Can go to the eye, which he had actually eye issues. Vestibular dysfunction, so he had a little bit of walking difficulties afterwards. It can actually refer, if it's low enough in the spine, refer to the chest wall. And so these highlighted points in red, I'll just let you read, but I won't necessarily go over for each slide. Also, axial pain can relate to that spondylosis that I was mentioning, which is a progressive deterioration of the osteocartilaginous components of the spine, most often related to aging, but often can be affected by trauma. So pain from the facet joints, which are identified here, that stabilize the spine, can also cause headaches. In addition to neck pain, it can also refer in expected patterns, depending on the level of the facet joint that's affected, refer towards the shoulder, refer towards the shoulder blade. And so sometimes we try to match that to identify the particular joint that's affected. He had a motor vehicle accident, so pertinent to this is whiplash, and up to 50% of pain after whiplash can be from facet joints. Subsides over time, but I think it could be a big contributing factor to ongoing pain. And then on top of all this is the musculoskeletal system reacting to deeper pain like the disc or the joint. And so a lot of times people like over 50% will have muscular tension, even if they're just, especially if they're sitting at the desk for long periods, their muscles get overused and fatigued and deconditioned. Facetogenic pain can often underlie muscle spasms. So people who have facet issues might just describe their symptoms solely as, I just have muscle spasms. And then myofascial pain with these trigger points are often is described as a presence of palpable trigger points, which are taut muscular bands that can refer in a defined pattern, especially when palpated. They can refer spontaneously without palpation, and that would be an active trigger point. But if it's elicited only with palpation, that can also be sort of a confirmatory diagnosis. Often the muscle tension for these taut muscular bands can actually clamp down on certain peripheral nerves that travel through the muscle layers. They travel up through the scalp, such as most prevalently is the occipital nerves. The greater occipital nerves, they come off of medial branches of C2. A third occipital nerve comes off of medial branches of C3. Patients can report this as paroxysmal shooting or stabbing pain, electric-like shock pain that radiates from the occiput all the way to the vertex and also retroorbitally. They may also describe sensitivity to the scalp by touch or sensitivity to pressure. In our particular patient, he has obstructive sleep apnea. He has to wear a CPAP device to help him breathe overnight. And he described that that's the strap that ties around, that ties the CPAP to his mouth, wraps around right over the occiput where these nerves travel. So he does report some of this happening to him. This is just a picture of the distribution of where pain or symptoms might be felt by affected nerves. And here is just, as I mentioned, the muscle layers that occipital nerves have to travel through that make it more likely that muscle tension can cause a neuralgia of these nerves. Now, if we're thinking outside of axial pain, we're thinking more radicular pain that goes down particular dermatomes, then we think about cervical dermatomes, which really affect the arms, possibly down to the armpit, but not so far. And so we think about areas that might affect the nerve roots, whether it's the neuroforamen, where it's the exit of where the nerve roots exit the spine, or the central spine, where the spinal cord travels down the spine. And then moving to physical exam, if we have these the differential diagnosis in mind, we try to keep things, we try to sort of focus the physical exam and tailor it to testing out the items on the differential. But typically this is the sort of the more comprehensive description of everything that we have to go through if we don't have anything particular to look at. Patients will often present with just neck pain, and it's very non-specific. So we look at the muscles of the neck through inspection. We look at the spinal alignment, look at how their head sits, their posture. They have some kyphosis. We ask them to move their neck, cervical range of motion, and see the degree that they're able to achieve that and whether or not that's provocative of any of their symptoms. So then we do palpation specifically to identify either a midline pain that suggests disc type of pain, or muscular or facetogenic pain, which is off to the sides of the midline, which we call paraspinal. And then if we're thinking about neuralgias, we'll probably tap on particular areas that we know historically elicits that neuralgia pain. So like a Tinel's. So we tap on the occiput to see if the great occipital nerves are involved. We also tap on particular areas of, we know, peripheral nerve entrapment at the medial elbow for the ulnar nerve, the volar wrist for the median nerve, which is commonly carpal tunnel issues. We do specific tests or special tests. This one particular is Sperling's, and the description of Sperling's is variable, so different folks will do it differently. Some will incorporate neck extension, so have the patient look upwards towards the ceiling. Other folks don't do neck extension, they just do rotation and tilt. Other folks don't apply direct pressure on the head. Some people will apply pressure on the vertex of the head to increase the sensitivity of the test. What it does is really to close that neuroforamen around the spinal nerve root and elicit or provoke any type of impingement that might be happening that would help confirm, so rule in or rule out a radicular issue. It is limited by the sort of the degree of sensitivity and specificity. So it is more specific. So if it is positive, it will indicate more likely than not there is some nerve root impingement. And I won't go through each aspect of this, but we do run through the motor exam for strength, using particular parts of the exam to help us identify which particular nerve root is involved. We also go through the neurological exam for sensation. This you might hear a little bit more from maybe a spinal cord injury talk, but this is what we call the ASIA exam, or American Spinal Injury Association examination of the run through of all the dermatomes through particular points of testing in the body that can help focalize which particular nerve level sensory deficits are actually coming from. And then we'll use reflexes to identify or distinguish between upper motor neuron issues, suggesting something that is in the spinal cord or spinal canal versus lower motor neuron issues, which is something that is essentially distal to the spinal cord, which is nerve roots or peripheral nerves. So that's really the relevance for reflexes for our parts of the exam. And then there are specific, upper motor neuron testing that we do. One is called the Hoffman's response. And if it is positive, that suggests something that is upper motor neuron. Because we're also concerned about myelopathy, and like we mentioned, if it was central canal stenosis impinging on the spinal cord, we'll also test out the lower extremity reflexes as well. And if there's a Babinski reflex, which is the upward pointing toe, which would indicate some upper motor neuron condition, that we kind of also look at if there's increased reflexivity or hyperreflexia in the patella and the Achilles, that makes it all consistent with something that's actually happening, upper motor neuron. That makes us a little bit more concerned about myelopathy. So for our practice in spine and pain, we always kind of keep in mind the anatomy. So with PM&R, I think outpatient practices rely a lot on knowing the musculoskeletal system, the attachments of muscles, the tendons, the ligaments, as well as the nerve distributions, where nerves lie. And I think this is very relevant for our type of practice, where we just have to keep in mind the brachial plexus, the lumbosacral plexus, in terms of directing our differential diagnoses as well as physical examination. So it's also important to rule out whether things outside of the spine are actually the causes of the symptom. So we'll do a shoulder exam, especially if we're looking at neck disorders. So we'll do a shoulder exam to rule out shoulder pathology, rotator cuff pathology, arthritis. This patient did have shoulder issues, so we had to do that for him. We'll do special tests to identify different parts of the brachial plexus that might underlie his dysesthesias in his upper extremities. Beyond that plexus, distal to that, we'll also do some neural tension tests for each of the individual large fiber nerves, the median, the radial, the ulnar nerves. The series of 3 pictures here on this slide are the special types of tests that we do for thoracic outlet. And it basically identifies particular locations of impingement. So the Adsons will try to test out whether impingement is happening from the scalene muscles in the neck. Edens will test out whether there's a costoclavicular impingement between the clavicle and the first rib. And the Wright's exam will test out whether there's a tight pec minor muscle. Okay, and then this is neural tension testing of the different nerves in the arm distal to the plexus. So going back to our case, what did we find? So on physical examination, palpation showed tenderness of palpation in the upper trapezius, worsened with extension of the neck, so looking upwards, and tilting his neck to the right. So that to me suggested something might be a combination of facet pain and then reactive muscle pain on his upper trapezius. There's also tenderness of palpation in the right paraspinal and occiput areas. So involvement of the paraspinal areas, paraspinal muscles, which could potentially impinge on those greater occipital nerves that causes his occipital headache and vertex types of headache. So we're thinking maybe there's a neuralgia happening with the occipital nerves. Some diminished light touch sensation on D3, which is the third finger on both sides, which based on the dermatomal distribution, that may suggest there's some involvement of a C7, radiculopathy on both sides. It could also suggest maybe there's a radial nerve component, maybe a median nerve component, because those peripheral nerves also affect the third fingers. Reassuringly, he had normal strength, normal sensation, and reflexes. So we weren't really concerned about any upper motor neuron issues. So once we've seen the patient, we kind of determine whether or not we need to do further diagnostic studies. MRI, CT, EMG studies are the advanced diagnostics that we typically pursue. MRI is the most commonly used, and then CT scans probably a surgeon would order. But if we end up seeing anything that travels, radiates or refers out of the neck down the arms, suggesting nerve involvement, we'll think about doing an MRI. So MRIs are really great to look at soft tissue injury, disc herniations, impingement of the nerve roots, edema, maybe bone healing, tumors. And then CT scans are really just 3D x-rays that allows us to look at bone spurs, disc calcifications, if this is a known chronic issue, especially if MRIs are contraindicated and if they have a pacemaker that's incompatible or spinal cord stimulator that's incompatible with MRI because it's a large magnet, aneurysm clips, then we have to rely on CT scans. And there are special types of CT scans that we order if we really want to look at the nerve roots, which involves contrast. Again, with MRI, there is false positives, false negatives. Here, just to highlight this, is that the MRI may identify the affected nerve root in 73% of the time. So not all MRI findings are actually clinically relevant. So that's fairly important, and that's what we actually educate our patients on, that we can see multiple findings. They may be very concerned about this or that, you know, the radiologist will call it as severe or something, but they have no symptoms on the left. They have these findings all on the left, but their symptoms are on the right. So in those cases, we'll have to educate and say, you know, MRIs, we don't treat the MRI, we'll treat the patient's symptoms. If we're doing EMG or nerve conduction studies, which EMG is electromyography, and nerve conduction studies, these are ordered to evaluate if there's spinal nerve root abnormalities. If we can't really differentiate whether it's coming from the spine or from the plexus or from the peripheral nerve roots, the EMG study, in addition to an MRI, will help confirm whether, or the presence of nerve root dysfunction, or a plexopathy or peripheral neuropathy. And then it'll help identify which nerve roots might be affected, the severity of that, and whether or not there's actually reinnervation or healing of a remote chronic nerve injury. Again, this has also its sensitivity. And so there's a timing in terms of ordering the EMG that it won't pick up any problem if the injury happened too recently. So a non-diagnostic test does not exclude a possible nerve issue, whether it's because of timing, whether it's because it doesn't pick up small fiber problems. It only looks at large fiber problems. Large fibers being things like the median nerve, the ulnar nerve, or the radial nerve, and the small fiber problems being like C fibers that are just very sensory. So going back to the case, we did do an MRI for him that showed disc degeneration at C3, 4, 4, 5, 5, 6, 6, 7, associated to disc degeneration. When those kind of when discs kind of lose their cushioning, a lot of the biomechanical body weight, daily activity stresses get translated to the vertebral bones. And you'll see maybe stress response or inflammation in the bones that the field just calls modic changes at the end plate, which are the surfaces of the vertebral bodies. He also had disc osteophytes, which are bone spurs that follow or accompany disc degeneration. He had mild facet arthritis, so those joints are a little bit irritated. He had severe foraminal stenosis, so on both sides, which is where the space where the nerve roots exit. So this is just one section of his MRI. So we can kind of look right down the central canal on a side view. This is a midline cut right through the midline, and he's facing towards the left of the screen on the left half of the picture. The plenty of cerebral spinal fluid, so the white fluid surrounding this dark spinal cord that runs through the canal. But the vertebral bones kind of they're not fully square on this cross section, so they looked kind of like the corners are pinched. So those would be the osteophytes. And then these dark sort of areas are the discs. So certain discs higher up are a little thicker or taller, and then discs here where the yellow line crosses are a little flatter, and those are show disc degeneration. So the cross section of where this yellow reference line is shown on the right half of the screen, and then we get a sense, and I'll just point this out to you, that this is the area where the nerve roots exit on either side, and it's a little pinched. So that's what is the foraminal stenosis that they're referring to. Here's the central spinal cord, and there's plenty of spinal fluid around it, this white margin around it. So the main issue, I think, seemed to come from the foraminal stenosis for him. We also did a EMG study to help us determine which nerves were involved. There was evidence of peripheral polyneuropathy. So that suggests that there is some issue that's affecting this sort of, not the large fiber nerves, but maybe smaller fiber nerves are involved, but there's evidence of this. There is also evidence of moderate median neuropathy at the wrist, which is essentially carpal tunnel issues. So this particular finding suggests there's a peripheral nerve issue, the median nerve. Median nerve being involved, I think, would correlate with his third finger sort of loss of sensation or diminished light touch sensation. There was also finding or evidence of a left ulnar peripheral neuropathy at the elbow, which is another area where we tested out on the physical exam. So that correlates with dysesthesias on the ring finger, possibly a pinky finger as well for the left. And there was chronic left C5 radiculopathy, although I think his symptoms may not necessarily correlate with this C5 issue. So once we have our information, we kind of move on to treatment. And so just to describe physical medicine and rehab, really we try to incorporate multimodal approaches, multidisciplinary care. So we work in a broad team that incorporates not just us as the physician, but physical therapists, acupuncturists, chiropractors, pain psychologists, all sorts of different practitioners between departments, so neurology, rheumatology, all sorts, and then even among different subspecialties in rehab for complex cases. And for this patient, maybe even sports medicine might have needed to be involved. So we really try to optimize conservative management, typically through what we already did so far, diagnostically, and then pharmacologically with medications, physical therapies for rehabilitation, interventions like injections that we do, maybe cognitive behavioral approaches that fall within rehabilitation and the physical therapies before we try to, before we exhaust options that then sort of the last resort is probably something surgical if needed. This is a typical sort of catalog of everything that we kind of keep in mind in terms of coming up with a treatment plan. So everything sort of related to medication options that are going to be very focused on the type of pain we're trying to address. So anti-inflammatories or steroids, we're trying to reduce inflammation. Muscle relaxants, we're trying to reduce myofascial pain or spasms. These antidepressants and anti-seizure medications are really the class of nerve pain medications that we use to address nerve pain. Down here is all the physical therapy types of approaches and the modalities. On the right upper column is the complementary approaches, the psychological therapies. Then we go to procedures to address particular pain sources that we can identify. And then these regenerative approaches that are more sort of less supported with evidence before we get to the surgical. So we keep in mind this multimodal approach. All of these types of approaches we can introduce or reintroduce down the road. If things seem to have diminishing effect, we might kind of revisit something that we tried earlier to address chronic pain. And so this is what we try to do, multidisciplinary integrated care. So rather than having the patients go to multiple different departments, we try to use sort of our PM&R training to synthesize everything and help coordinate this whole team, if you will, of providers to address a complex issue. So for this patient, the assessment was from the exam, from the diagnostics, he had some myofascial pain, possible occipital neuralgia causing his headaches, radicular or nerve root pain coming from those foraminal stenoses on both sides, possibly nerve-related underpinnings for this itchiness he's getting on these both arms, and then some pain from those joints. The plan we came up for him was, continue to cycle through different options for medications for muscle relaxation, nerve pain, inflammation. We pursued an epidural steroid injection, which actually helped relieve a lot of his upper arm symptoms with lasting effect, and that's probably already 2 months now. We are pursuing a series of treatments of trigger point injections, which are really small needle types of procedures for the muscles, to relax his muscles, which are helping substantially. And then we did some nerve blocks, which is again, putting lidocaine next to those, possibly steroid next to those irritated occipital nerves. And of course, everything involves patient education. So we do run through pain, the psychology of pain, pain experience, the sort of how pain becomes chronic. There's going to be ups and downs. We'll have more pain one day, less pain the other day. And that's just a part of the process. But as long as we rule out red flags, significant issues that might cause a structural problem and cause severe issues, we are essentially working with his pain issues. The plan also did involve multidisciplinary care. So just for his multiple other problems, I recommend a referral to neurology to work on his visual issues and balance. We try to look at an ultrasound dynamic to look at whether his nerves in the arms were causing subluxation or getting impinged there. He needed some braces for his carpal tunnel, so I recommended that for his wrist. Because of multiple fractures, I recommended him to Skeletal Health to really optimize his bone health. And this is part of the preventative care and sort of what aligns with medicine that we do, is to make sure we stave off future problems or recurrence of problems. And then he had this question of connective tissue disorders because he presented with hypermobility. So, the thought was maybe start with rheumatology to see if there is a rheumatologic connective tissue issue, or possibly then go to genetics to sort of tease that out. So referrals, we are, as a specialist in PM&R, what type of patients get referred to us for spine in particular is they need spinal workup. They want to have us look at advanced imaging or studies, then to interpret those advanced studies, management of ongoing chronic refractory symptoms that the initial care, maybe a primary care physician saw them earlier, tried physical therapy, but it didn't really help out. So then we have to sort of help along with a more complex case down this road. And then just continue to manage chronic pain patients. We also provide those interventions that I described there. And then we kind of also serve as triage in terms of flagging down, more concerning issues. We can work in tandem with our orthopedic surgeons if we identify red flags that indicate some surgical intervention is needed. So I was asked to just kind of go through a typical day or work week. So for the most part, we see patients in clinic, we kind of do all of the above. We evaluate, we kind of go through image findings. In clinic, certain people will have training to do procedures, ultrasound guided procedures for injections, typically of joints, but also we can target nerves to block out nerves that possibly are impinged and causing pain. In clinic, we also do trigger point injections. These are the small needle injections to release muscle tension. And then the advanced procedures for spinal injections under X-ray guidance. So we do epidural steroid injections, deeper joint injections in the spine, maybe nerve blocks. So a collection of different things. My typical work week is, there's an academic day, 3 clinic days throughout the week. One of them has ultrasound injections or in-clinic procedures, and then X-ray guided spinal injections on another day. So I'd like to stop it there. Thank you for your attention. If there's any particular questions, either about cervical disorders or my specialty or our field, I'm happy to take them.
Thank you so much, Dr. Wu. This is Casey here. I am helping to run the course with Eva May and Ariana, but Ariana had to step out. While you were talking, we had a question come in over the chat. So Ted McLeod was wondering how you came to choose PM&R in the first place, and then specifically spine disorders within the other subspecialties within physiatry.
My background was engineering, and I think that to me led to biomechanics as a subset of engineering. So I was naturally interested from there on translating the engineering to something clinical or medical. And then it kind of made sense because mechanical engineering kind of what appealed to me from that standpoint was the musculoskeletal system. And then I think that decision sort of at each point of the training, you'll probably get more information or learn more about it that sort of redirects you down different branch points. So I think when I got towards rehab from the engineering background, I naturally got interested into the holistic type of approach, the multimodal approach that it did. I found it fascinating that pain was involved with the psychology, the behavioral, a lot of the social factors as well. So I think pain kind of appealed for me once I got down that road.
And I guess one follow-up question is, I'm wondering if, do you get the sense that across physiatry, people really do think of sort of rehab, but then also pain as sort of this holistic diagnostic and treatment thing? Or do you feel like that's sort of a specific area within PM&R, or is that the overall philosophy of it?
So within rehab or generally within the pain field?
I guess I'm wondering about both, sort of, yeah, within PM&R generally, and then within pain, whether it's PM&R or otherwise.
PM&R probably is more, it readily sort of has an inclination to involve the multimodal approach, just because the training involves working in teams and multiple different specialists from the very beginning. So I think that sort of naturally fits into the PM&R philosophy. I think in the pain field, it may have taken different timing. I know that from the anesthesiology fellowship programs for pain, they are incorporating more PM&R approach, sort of multimodal approaches. So I think the pain field does recognize the contribution of PM&R to pain medicine, right? So it's not just all about procedures. They do really emphasize physical therapies. The pain psychology is a big part of it. And so a lot of education and meeting with a cognitive behavioral therapist is a big part of the pain management plan. And then just, I think what's emerging more, but it's kind of also limited by reimbursement, is having functional restoration programs. So in the name itself, functional restoration is sort of a goal or philosophy for rehab, which is to restore function. And these programs are really for chronic pain patients where they've gone through a lot. There's not a lot of anatomical problems that will lead to severe detriment. They have problems, but they're really working around a chronic pain condition. And so how do we get them back functional is through these types of programs.
Interesting, thank you. And we're just about out of time, but I do want to read this last question coming from Sarah. And of course, anyone who needs to sign off, go ahead and do it. But Sarah is wondering if you could explain a little more about the patients with a disconnect between the MRI findings and their clinical presentation. And she says that she's had trouble finding a way to get patients to buy into the fact that MRI findings aren't necessarily the same.
Yeah, so I almost kind of said it the way I would say it to my patients in the talk. I'll say it to them and say, you know, we want to try to know where your symptoms are, because that's what's bothering you, that's limiting you. And, you know, we want to focus on that. And if we can correlate those symptoms to some finding in your MRI, based on our experience, that's what we would treat. And so the other findings may be there. We'll be watchful for those things and also kind of provide recommendations to prevent certain of those things from worsening. But I think, you know, we want to treat you as the patient rather than the constellation of findings on the MRI. Usually when they hear that, I would say at least 75% of patients will kind of agree, right? There's obviously going to be a lot of patients who are like, well, I'm not satisfied. Why is all this happening? But that might just take further explanation of why pain is there or symptoms are there.
Great, well, thank you so much. Really appreciate you taking the time today. And I feel like, I don't know if I'm just speaking for myself, but I feel like that pain medicine is of so much interest sort of across fields and within PM&R and outside of it. So thank you for coming to speak with us.
You're welcome. Thank you guys for your attention. Hope to see you guys in the future in our rotation.
Thanks.
Take care.